Physical exam specifically for the sacroiliac joint, please reference our other videos for information in terms of the typical clinical presentation for sacroiliac joint pain and dysfunction, as well as the considerations for treatment. And then we also do have a podcast on the Spine and Nerve podcast going over the sacroiliac joint, including recent expert opinion in terms of the diagnostic and treatment algorithm for sacroiliac joint dysfunction. But today, we're going to be focusing specifically on the physical exam maneuvers, the provocative physical exam maneuvers for the sacroiliac joint. So one thing that we talked about in our podcast, as well as our discussions of the typical presentation of sacroiliac joint dysfunction, is that this is a common cause of low back pain, but it can really look like a lot of different things, and other things can look like SI joint dysfunction. So, all right, guys, now in terms of the physical exam for the sacroiliac joint itself, remember, and we've talked about this in the podcast as well as the other discussions, that we're really looking for three positive exam findings, and that will give us a sensitivity around 85% and a specificity of around 76%. And the 5 recommended maneuvers, and of course you develop your own approach and you may do some additional maneuvers, but at least we should be doing the 5 which I'll demonstrate here today, which include the SI joint compression and distraction, as well as FABERs, Gaenslans, and thigh thrusts. So obviously we'll demonstrate all those, but what I like to do first on physical exam is to understand where I'm at anatomically, and this actually tells me a lot about whether or not I really think that this is sacroiliac joint dysfunction that we're dealing with. So the first thing I'll always do on the patient once we get them laying flat on their belly, and sorry Sean, my hands are cold here, but I first feel for the iliac crest, because typically, as we all know, that's generally going to be around the L4 region in the patient. So once you find that area, you identify this area, then you ask the patient, is your worst pain, your typical pain, the focus, the center of your pain usually at this region or significantly below this region? Because if it's facet pain, which obviously is something that can very much mimic and look like SI joint dysfunction, then generally they're going to be at this region or right below this region in terms of where the center of their pain is and where their worst tenderness to palpation is. So once you kind of know where you're at in terms of that L4 region, and you can move down to the L5 region, and then you can move laterally and a little bit more inferior to the posterior superior iliac spine, the PSIS region. And if the patient says, yeah, that's the center, the focus of my worst pain, and they have a lot of tenderness to palpation at the top of the SI joint there, then obviously that's going to make you start to think about the SI joint as one of the predominant causes of the patient's symptoms. If the patient's not in as excellent shape as Sean here, then once you palpate that top of the iliac crest, you can kind of walk down there until you can find that posterior superior iliac spine, and again use your anatomy to guide you to where the top of the SI joint is, because there should be a fair amount of tenderness to palpation there, and that should be the focus of the patient's symptoms. Now in terms of the provocative maneuvers, so a lot of the provocative maneuvers we're going to be doing here, aside from the tenderness to palpation at the posterior superior iliac spine, are going to be with the patient on their back. But before I go to that, this isn't necessarily one of the 5 highly recommended maneuvers, but you can do a Yeoman's here. Now, the caution I would say with a Yeoman's is that you can elicit a lot of facet pain with that. Generally what I do with the Yeoman's is you're going to lift the leg up to about a 90 degrees flexion at the knee. You're going to place your hand underneath the knee so that you're at the bottom of the thigh there anteriorly, and then you can place your hand on the low back. Now, if it's facet pain, theoretically, you can try to stabilize that the bottom of the lumbar spine and place more stress through the sacroiliac joint itself, so that you can kind of help determine, is this more SI joint pain or is this more facet pain? Of course, that's not a perfect fix for this test, but with the patient laying on their back, you've already done the anatomical landmarks. I think this is a reasonable test just to give you a sense, and you're just going to gently like with all of our exam maneuvers, you're going to gradually work your way into it. You don't want to do sudden movements, especially for people in a lot of pain that can really flare things up and cause distress for the patient. So, stabilizing in the lumbar spine with your offhand, and then gently bringing up with your hand holding the leg. And then with all of our exam maneuvers, you're asking the patient, does that cause pain? If it does, where exactly is it causing pain, and is that your typical pain? Because just pain with the maneuver does not give us great insight. It's okay, it's causing pain, but where exactly are you feeling that pain? Is that your typical pain that's really limiting you on a day-to-day basis? So now that we've done this work with the patient on their belly, I'll generally have them go ahead and turn onto their back at this point. Okay. So at this point, we can do the FABERs and the thigh thrust first. So with FABERs, we're doing hip flexion, and we're doing hip abduction, external rotation, and then as well as some extension. So essentially, as always, you're telling the patient to relax. You're being nice and gentle with your movements, and then you're bringing the leg down. Ideally the foot is around the knee area, but for some people who are in a lot of discomfort, that's okay if they can't, get to that point exactly. But bottom line, you're having their foot rest on the opposite leg, then you're stabilizing with your offhand around the pelvic, the anterior pelvic region on the contralateral side, and then you're gently pushing down. Now here, again, if they have pain, very important to ask them, okay, well, where's the pain? Because if they have intra-articular hip pathology, then they may have pain in the groin region, which may not necessarily indicate that this is definitively sacroiliac joint dysfunction. It may be intra-articular hip processes that are causing it. But if it reproduces their typical pain, especially in that low back, buttock, gluteal area, then it may indeed be a SI joint. And right from the FABERs, I can just go into thigh thrust. So, with any of your exams, you want to make sure they kind of flow, and obviously you create what works best for you, but it's good to have an efficient exam that really flows one thing into the other. So I guess the last thing I would say too is if it really hurts during a certain provocative maneuver, it's good to give the patient a second for things to calm down, because they may still be just feeling the residual of that most recent provocative maneuver you did. So let things calm down before you jump to your next provocative maneuver. Now for thigh thrust, you're bringing the thigh up to about 90 degrees flexion of the hip. And what I like to do is I like to hold the patient's thigh, so my forearm's kind of holding up their leg, and then this way I can put good solid pressure, even if it's a bigger, stronger patient. You can put good solid pressure using your axilla essentially. That's not going to hurt them too much, but you can put a lot of pressure downwards through that sacroiliac joint. Again, asking where it hurts, does it reproduce your typical pain? So while they're still in the lying down position, we can do the distraction test here. So essentially what you're going to do here is you're actually going to cross your arms, and you're going to be palpating for their anterior superior iliac spine. You're going to place the heel of your palm on one side and the other side, and then locking out your arms, and you're just pushing through, so essentially distracting that sacroiliac joint. The Gaenslans, and I'll show you the modified Gaenslans as well, which is sometimes a little bit easier to do for patients, but for the Gaenslan's maneuver, you put yourself right at the edge of the bed, tell the patient you're not going to let them fall, and then you say, okay, scoot towards me all the way to the edge of the bed, I promise I won't let you fall. There you go. The reason they need to be right at the edge of the bed is because this leg is actually going to dangle off, okay? And so here, obviously, we're looking for, in this patient, left-sided SI joint issues, and so we're bringing up the contralateral leg to a flexed position and holding that there with one of your hands, and then with the other hand, you're actually pushing through that sacroiliac joint. So in this case, the left sacroiliac joint. You're putting some downward pressure. And again, gentle, work your way into the maneuver, because obviously this can be very uncomfortable patients if they're really flared up in that joint. So that's the Gaenslans there. Now, in terms of the compression test and the modified Gaenslans, I'll go ahead and show those to you with the patient on their side. So we've gone over the FABERs, we've gone over the Gaenslans, we've gone over the distraction, SI joint distraction. So we'll go over compression and we've gone over thigh thrust as well. We'll go over compression and modified Gaenslans here. So for compression, go ahead and lay onto your right side here. Okay, so the important things here are that you want to find the top of the iliac crest and the trochanter. And then you actually want to push in the area between that. The reason that's important is because the trochanter is actually an area that is very commonly tender or sore. So you don't, when you're doing the compression test where you're trying to place downward pressure through those sacroiliac joints, you don't want to be pushing over the trochanter because that a lot of times can confuse your exam. But that also goes back to when you do have a positive test, where is it hurting and does that reproduce your typical pain? But like I said, you're finding the greater troch region, you're finding the iliac crest, and then between that, you're go ahead and push down through the sacroiliac joints. Now, modify Gaenslans in this position. So here, again, we'd be checking for the left SI joint dysfunction. Or left SI joint pain or dysfunction. Have the patient bring the contralateral leg, so in this case the right leg, bring the knee up towards the chest. Yeah, exactly. Great. And then you're going to grab the leg, the side that you're focused on, grab it at the knee joint and support it there. And then you're going to be placing your hands so that they don't roll backwards, and you're going to be placing your hands to kind of stabilize the low back and pelvic area, and then you're extending that hip there. So you've kind of created the same thing you did with the original Gaenslans, but here, and the reason I like this too is, number one, it may be easier for patients to tolerate, but you can really kind of control versus, with the other case, gravity's doing its part too, but here you can really kind of control how much extension or stress you're putting through that sacroiliac joint. All right, guys, I think we covered the sacroiliac joint exam there.